Hello and welcome to Fresh Perspectives. My name is Gail, and today my guest is Jillian Abata. Would you tell the viewing audience, since it's not printed on the screen at the moment, what your job title is? You're like a supervisor?
I think I have one of the best jobs in the healthcare profession. I am a registered nurse. I also manage the wound care center over at A.H.N. Westfield and A.H.N. St. Vincent down in Erie.
Yeah. Okay. And the wound clinic in Westfield is just open mainly 2 days a week, is that correct? And then you work the rest of the week in Erie?
Yes, so our team for the most part comes from Erie, from St. Vincent. Our clinic at Westfield is open on Tuesdays and Thursdays right now. We're hoping by the summertime at the latest we'll be able to be open on Wednesdays as well. We're working on bringing another doctor in so that we can make sure we give the community the best care.
Oh, good. I'm glad to hear that. Now, how did you get interested in doing this type of work? And what was your education like?
So I always knew when I was very little, I always knew I wanted to be a nurse. I don't have family members that are nurses. I just thought it would be so cool. I used to enjoy watching the show Rescue 911 with my mom, and I think that's kind of what played into where I'm at today with wound care. Going through high school, my grandmother actually had to have an amputation. And
was that a leg? Or?
Yes, yes. She ended up losing her leg after some heart surgery.
Oh.
She was not diabetic. And just seeing how it affected her, how it affected her quality of life and her personality, it really, really changed her. She was afraid somebody would notice now that she didn't have her leg and that she was going to be judged, and she really didn't want to leave the house anymore. So as a family, we noticed these changes, and it definitely changed who she was.
Mm-hmm.
So going through nursing school, I was able to do a rotation in wound care, and I was not expecting to love it as much as I did, but I really attribute that to my Nana. With all of the things that she went through for that amputation. So now being a nurse for 15 and a half years, knowing what I know, I get great satisfaction in my job and being able to tell patients we have done absolutely everything before they would have to go through that amputation process.
Oh, you try other things first?
Oh, we try everything. Amputation
Okay.
is really a last resort.
Oh, okay.
In what we do. The doctors at the clinic don't do that procedure, but we really do a lot of advanced therapies, a lot of testing, everything like that to make sure that we are doing everything possible.
Mm-hmm, mm-hmm. I just wanted to say, if people do get wounds and things, they want to really keep an eye on them, you know, and make sure that something gets done about them before it can turn into an amputation. There's this one woman that I know. When I saw her a few years ago, I hadn't seen her in a couple of years, and turned out she had lost her leg from what started out as just a tiny little scratch on her leg that got infected and wound up losing her leg and had to get one of those prosthetic ones.
There's in my very weird world of wounds, there's a lot of factors that go into wound healing. Mm-hmm. It's almost like putting together pieces of a puzzle. Mm-hmm. So not only do we want to treat the wound and make sure that's not infected, depending on where the wound is at kind of plays a factor, nutrition plays a factor, vascular status, if you don't have good blood flow down to your legs, if you don't have good control of the swelling in your legs, that could play a factor. Pressure can play a factor. So there's a lot of little bits and pieces that we do as clinicians to put together in order to figure out what's the best way to heal these wounds. It's more than just putting a Band-Aid on it and hoping that it works.
Mm-hmm. Okay, so one of my questions for you was that you run various different medical tests on your patients, right?
Yes.
To find out what the cause is?
Yes. So in our clinic, if we don't determine what the underlying cause is we could put anything on that wound. We could do very expensive treatment, we could do cheaper treatments, but if we don't treat the underlying cause, maybe it'll get better in the interim, but it's not going to be a long-term solution. So we do order quite a variety of tests. Typically, our doctors will order an x-ray to start if there wasn't one. They order blood work, and that blood work we check for all kinds of different things. We check your nutrition, we check some inflammatory markers to see if there's maybe an infection kind of in those deeper tissues. We check, your basic blood work. If you're diabetic, we might look at your hemoglobin A1C so we know how you're controlling that blood sugar over a period of time. We also, if you have a wound on your foot or your leg, we usually will order some vascular testing too, just to check the veins in the arteries. There's 2 different types of vessels in your leg. You have veins, which take the blood back up from your feet and your toes and your leg back up to your heart. And what we find is that sometimes patients with veins have issues with the valves in the veins.
The valves in the veins?
Could be hereditary. It could be they just got unfortunately lucky and have terrible veins. But there is a procedure that can be done to help with that and to help move that extra blood and that extra fluid back up the leg to prevent that swelling or at least reduce it.
Do they replace the valves then?
No, usually they do a procedure. Most of the time it's a same-day procedure, and they actually go in and they burn it off. So that's a procedure that's done either at the hospital or at the surgery center, and the vascular surgeon will go in, and they don't put you completely asleep for it. I know a lot of patients are afraid of anesthesia, so they just give you something, kind of a light sedative, and they go in and they just burn those leaky veins. The test that we do for arteries, because your arteries take the oxygenated blood from your heart down into your leg, into your foot, and into your toes. The test we do for that is a little different. So usually when our patients come into the clinic with a wound on their foot or their leg, we're very, very focused on, is their foot cold? Can we feel a pulse? Can we hear a pulse? What does that pulse sound like? Kind of a thing. Usually, if you have issues with your arteries, you're going to come in and tell us, I can't sleep in bed. I can't keep my legs up. I get terrible pain in my legs. I get terrible pain in my toes if my legs are up too long.
You mean if they're in a laying down position too long? Is that what you mean?
Yes. Yep. If they're in a laying down position and their leg would be kind of even with their body if they're laying flat. These patients will come in and say, I can't, it drives me crazy. I get this terrible pain. Once I get up and walk around, it's better. So that's kind of a signal to us that it could be an issue with the arteries. And when you stand up, the force of gravity actually pulls just a little bit of extra oxygen down to that area to relieve that pain a little bit. So there's different procedures that our vascular surgeons can do to fix the arteries as well. Sometimes our patients come in and it's a mixture of venous and arterial, so now we have to look at both of those pieces to put that puzzle together to come up with a treatment plan.
So in other words, you have them get, what do they call the test that you test for that?
So we usually do, it's called an ankle brachial index, or an ABI, and that involves the vascular tech will put blood pressure cuffs on the leg and take different blood pressures. They'll do it in the arm, they'll do it in the leg, and they compare. And that result is what tells us kind of how good that blood flow is down to those areas. The venous test is a little more involved, and there's 2 different types of venous tests. It just depends on what we're looking for that.
Okay. Now, how long has this wound clinic been in Westfield, and would you tell the viewing audience what the location of it is?
So I started with A.H.N. in September of 19. I do know that the clinic in Westfield was there well before that. Exactly a date, I'm not positive. But when I first started with A.H.N. in 19, it was only a day and a half a week. And now we're up to 2 days, and like I said, by the summer we're hoping to get to 3. The A.H.N. Westfield Clinic is right next door to the hospital, to Westfield Memorial Hospital. We are in a little building called the Myers Professional Building. So if you're looking at Westfield Hospital and you're looking at the front door of the hospital, to the right is going to be a school. And then to the left, there's this little building. There's a sign out front. It looks like a little house. We're right in that little house. We have our own little parking lot and everything.
Somebody told me that that was a house where a doctor and his wife lived many years ago.
It was, and I'm under the impression that they had either left it to the hospital to use as they see fit, or they gifted it to the hospital. Somehow they left it, and so we turned it into our little wound clinic.
I know it's been used for a lot of things over the years. They've had various different doctors and like that who come from, like Erie and like that to see patients sometimes. But is it just being used for the wound clinic
Yes,
now?
now it is solely used for outpatient wound care.
Oh, okay. Okay. Everything has changed so much,
Of
know,
course.
so I didn't know if other doctors were still coming in there or not.
We live in an ever-changing world.
Okay. Now, in order to be treated at the wound clinic, do people have to be referred by their primary care doctor or another doctor who's been treating them for something, but they feel that they need your help? It has to be a referral then?
Yes. So even if your insurance company does not require a referral, we do. We are considered a specialty practice, but we require that referral for a few reasons. One, so that we can look at your record and kind of have an understanding of what's going on with you and your medical history before we even see you. That starts to give us an idea of how to create that customized treatment plan and gives us an idea of which direction we think that your treatment needs to go or to start. We want to make sure that we give you enough time so that we schedule that slot appropriately too. We don't want to rush through your visit. We want to make sure that we really are looking at all those little pieces and putting them together.
Okay. Okay, now how many people actually work at the Westfield Wound Clinic, and what are their job descriptions?
So right now I have two physicians. We have Dr. Wayne Jones and I have Dr. Fred Havco. We are looking to bring Dr. James Lane in once he gets on board with some of those New York insurances, because all of our docs also work at St. Vincent, and they do work in Erie too. So crossing that state line gets a little tricky with those insurance companies.
So they have to be licensed, have more than one license then? They
Yes, so our physicians are dual licensed in Pennsylvania and New York. Our nurses that go to Erie and work at St. Vincent are also dual licensed in Pennsylvania and New York.
Okay.
But when you start talking with insurance companies, we do a lot of treatments that can be a little expensive. So we want to make sure that your insurance covers it, so you don't end up with this big fat bill and then get really mad at us. So we're just waiting for Dr. Lane to get on board with some of those payers. We have, 3 LPNs. I have myself, I work in the clinic as well. I have another per diem RN, and then we have a registration person.
Okay, now a registration person is somebody who works in the office.
Yep, she works at the front desk. So if you call, typically she's the one that's going to answer the phone. If you need to reschedule, when you come in to check in for your appointment, she's the one that will verify your insurance and your address. She'll take your copay. She usually will reschedule your appointment for the next time when doc wants to see you.
Okay, now what are the various kinds of wounds? You treat a wide variety of different kinds of wounds at the wound clinic.
We do.
Okay, what would they be?
So we see pretty much anything open and draining that hasn't healed with your typical measures, right? With your ointment and your bandage. We see a lot of diabetic foot ulcers. It is so important for diabetics to check their feet every single day and to wear actual diabetic shoes and always have something on their feet, just because they are at higher risk. A lot of our diabetics can't feel their feet. If they would get a sore, sometimes they don't know that they have a sore on their foot, and that can, at the end of the day, lead to amputation. We see patients that have, we call them pressure injuries now, but they're also known as bed sores.
Oh,
A lot of
okay.
our patients, if they are confined to bed or a wheelchair, maybe they had a stroke and they can't move as well. Maybe just they're older and their disease processes make it really hard for them to get out of bed, or they sleep in a chair and they end up with bed sores. We see a lot of those. We see a lot of issues on the lower legs, whether it's a venous issue or an arterial issue. Those can lead to wounds as well. We see some surgical wounds that don't necessarily heal as the surgeon had expected. Sometimes there are complications with that where those wounds will kind of open back up. So we see those as well. Sometimes we see wounds that maybe the patient had cancer and they had the skin cancer removed, and now it's what's left from that skin cancer now that that's been removed. So we see quite the variety. We are very, very selective with burns.
Okay.
We are not a specialty burn center. We are not designated as a burn center. So if the referral would come in and that burn is in a certain location, we might say no. Because we wouldn't want to miss something in that super specialized care that would affect the function of that area. So if you have a burn on your hand, not being a specialty burn center, not having access to some of those tools and a lot of those different things, we would probably say you need to go to a burn center because we don't want you to lose function of your hand if there's any damage.
Now you're talking about a bad burn, right? You're not talking about the little first-degree burns we get.
Typically, if it's more of a superficial burn, we can handle it. Sometimes it does depend on how big that burn is. So when you talk about burns, you talk about body surface area. So if it's a burn on the tip of your finger, we probably could take care of it. Now, if you're talking about you stuck your hand in a big deep fryer because you're reaching for something, that's something we would definitely recommend going to a burn center for.
Okay.
But we work with a lot of other specialists as well to get our patients care. Sometimes if the wound looks a little suspicious or it's not acting the way we would expect, we do punch biopsies at the clinic, and sometimes those do come back as cancer. Sometimes they do come back as something funny that we might need a general surgeon to take off, or we might need a vascular surgeon. So we definitely work with a lot of other specialties in the medical profession to make sure that our patients get taken care of and they get to the right place.
One other thing I wanted to say about people who are diabetic, they should have their toenails trimmed by a podiatrist. Is that correct?
Yes.
Not try to do it themselves?
No, we absolutely do not want our diabetics to trim their nails themselves. We do see it on occasion where a patient will try to do it themselves and they end up nicking their toe, they cut it too short, and now they have an open wound, and that can certainly lead to complications. A lot of our diabetics, not only do they get that neuropathy in their feet where they can't feel their feet, they also get it in their hands. So we really try to educate our patients that if you are diabetic, your insurance will typically cover a routine visit with a podiatrist every so many days, so that they can really check the feet and trim the nails and everything.
Okay. Now, another thing that I'd like you to describe how it happens is wounds that are caused by venous or arterial problems. Does that cause pressure that causes the person's skin to open up?
So there's two different systems. So we'll talk about veins for a minute. So your veins are what bring that blood and that extra fluid back up. Right? So your veins have to work a certain way to get enough pressure to build up. When your veins aren't working properly, when there's issues with those little valves in the veins, what happens is, first of all, typically our patients will see swelling in the leg. Your leg is like a water balloon. So it can only hold so much of that extra fluid before that fluid has to go somewhere, right? Or before that fluid bursts. So a lot of our patients with venous issues will come to us and say, yes, I've had swelling in my legs for a long time. I get these little blisters.
Oh, okay.
And those blisters open up. And then sometimes, they can heal on their own. But usually if you have issues with the veins, we're going to recommend compression as long as your arterial flow is okay. And usually those patients will be in compression socks for the rest of their life.
Oh, okay.
There are a lot of other factors that can impact that swelling too. If you eat a lot of salt in your diet.
Yeah,
so if you're eating a lot of canned, whether it's, I know it's getting colder, it's cold today. If you're eating a lot of canned soup, there is a ton of salt. If you're eating canned vegetables, some of those pre-prepared meals, there's a lot of salt in bread and cheese, especially if you're adding salt to your food. Salt and water are best friends. So they're going to stick together. So if you have a lot of salt in your diet, there's a very good chance you're retaining a lot of extra fluid and extra water. The arterial issue, most of our patients with arterial disease that come to us is because they maybe they were a smoker for a long time. We all know smoking is terrible for you. It's also terrible for everything. It's terrible for your vessels in your legs. It's terrible for your feet. So typically with an arterial wound, not only will these patients come in and tell us about the pain they're having and they can't elevate their legs and this and that. If you have an arterial wound, to us, that's a sign that there's a blockage in that artery. So you're actually not, because of that blockage, that blood can't go through that artery. So you're not getting blood there. Essentially that area is kind of dying from not getting blood and not getting oxygen. So we typically will recommend a referral to the vascular surgeon pretty quickly if we think that's the case. Hopefully we get to it in time. On occasion we do see patients that maybe they've had these sores for a long time and they're afraid of doctors, or they had a bad experience with a doctor, and they haven't gone and they've been putting it off and putting it off and putting it off. Unfortunately, we do see cases that it's too late and there's not a lot that can be done at that point. So we really encourage, routine visits with primary care so they can address some of those things. And seeing a doctor when you notice these issues. The longer a wound is open, the higher risk of infection it becomes. So we really like to keep a close eye on some of those patients.
Yeah, I know that people with congestive heart failure can get swelling in their legs and openings in the legs.
Yes.
Where the fluid comes out. And quite often those people are people that don't want to adhere to a low salt diet.
We, in our weird world of wounds, patient compliance and patient adherence is a huge issue. So we, when you come to the wound clinic, we might see you for an hour a week, an hour every 2 weeks. But the rest a lot of it is up to the patient. If we tell you, hey, you need to wear this compression to keep the swelling down in your leg, we got your leg healed, but you need to stay with this compression, you need to stay with this compression. We do see it where patients, will come back and say, oh, I wasn't wearing my compression, or, I had this bed sore, this pressure injury from sitting on my couch or sleeping in my recliner and not using my cushion, or, whichever, and that area opens back up because the patient maybe they can't tolerate, sleeping in bed, or they're not turning and repositioning enough, or they're not changing the dressings, or they're not getting those tests that we order done. There's a lot of factors for patients not adhering to the plan of care.
Oh, yeah. Okay, now you've brought some things to show to the viewing audience.
Yes.
So we'll get them out now, and you can
yes. So
explain how you do some of the things that you do. I wouldn't want to try to put it into words, but hopefully you can.
So if we determine that the issue is a venous issue, right? The gold standard to treat those venous ulcers is going to be to compress the leg. So at first, before we get that testing and before we get those results, we might use something like this. This is called a tubie grip, and it is just tubie grip. Yep, and it's just a very light kind of compression sleeve, and it would go. Your toes would be out, and it would go up just below the knee. So this is kind of the very, very light first layer of compression. So we usually will dress the wounds and then we'll start with something like this. After we get that venous testing done and that arterial testing, we know it's safe to compress the leg to a certain amount. We might move to something like this. So this is a 2-layer compression bandage or a 2-layer compression system. It is similar to a soft cast. So it starts at the base of the toes, and then we wrap it around the foot, and it actually goes up right below the knee. And what this...
Do you mean that you're wrapping it kind of like an ace bandage or something?
Yep.
Starting at the foot?
Yep, right at the base of the toes. So right about there.
Okay.
And then it goes up the leg. And what this does, not only does it compress the leg, but it uses the muscles in your calf when you walk to help push that extra fluid back
Oh my
up.
gosh.
So, because we know that that's a huge contributing factor to some of these ulcers. So we use this system. It goes this nice foamy, cushiony layer first, and then this other brown layer. This is the only color they come in, ladies, sorry. But usually we do put a black stocking over top, so it's not as obvious that there's something going on.
Well, a lot of people that maybe don't want all that stuff to show can just make it a point to wear long pants all the time instead of shorts.
And sometimes that does work. The next thing I brought to show, this is a type of a compression stocking. One of the biggest issues with our venous patients and wearing their compression is they can't get them on. Some of our patients can't bend down far enough to get to their toes. Some of them, maybe they have rheumatoid arthritis in their hands, and with how tight those stockings are, they can't pull them up, they can't get the wrinkles out, so then they don't wear them. Well, we do have a solution for that. So this is a type of compression wrap, and this is one of my favorites. This one, I mean, it's my favorite in the winter. I don't know that it would be my favorite in the summer. This one is a Velcro compression wrap. So it slides up over the leg, just like a knee brace almost. So you put it on over the leg, and then you use these straps to tighten it. So then the straps are what provide that compression.
So you have to pull the whole thing over the foot.
So you do have to slide it over the foot, but this is definitely more forgiving than one of those compression stockings. We do use a variety of dressings in the wound clinic too. When we determine how to treat the wound, right? Not only are we looking at all of those other factors, right? We're looking at your diabetes control, we're looking at your diet, we're looking at is there pressure, all of those things. But when we decide what we're actually going to put on the wound, we usually ask ourselves, what is the wound doing? I know when I was growing up even, it was always leave it open to air. It needs the air to get to it. That's actually not true. We do not want air getting to our wounds. We always want to keep them covered. So there was research done back in the late 60s, and what they determined was when you keep a wound covered, the temperature of the skin and the temperature of the cells in that wound maintains itself so that those skin cells and those epithelial cells, is what we call them, can reproduce at an accurate rate to help promote healing.
So you want warmth.
Yes, not necessarily heat. I don't want everybody that has an open wound to go put a heating pad on now.
No.
But we just want to make sure that these wounds are covered. That research study showed us that when you uncover a wound, right, when you take off that dressing, it actually takes 4 hours from the time it's covered back up for that temperature in those cells to
it takes
rise.
4 hours for the temperature to get back to what it needs to be.
So if we change the dressing too much during the day, that's really not, it's not saying the wound is not going to heal, but it's going to take a lot longer than that. Wound care is a balancing act. We want to make sure that our wound is moist. I know a lot of people have issues with that word, but that's what we want to do. We want to make sure it's not too wet and drowning, but we want to make sure it's not too dry. So a lot of these little dressings that we use will do that. So this particular dressing, this is one of my favorites. This is considered a non-adherent dressing. So it should not stick to the wound. It is medicated. and it does have a little funny smell to it. This is called Xeroform. This is one of my favorite dressings. A lot of even the primary doctor's offices carry this too. This is good for some of those more superficial, not very deep wounds. One of the other types of wounds that we see, they're called skin tears. So
Skin tears?
Skin tears, yep. So our patients, maybe they rubbed their arm against the doorway, or maybe they fell and they scraped their skin and kind of that top layer comes off. It bleeds like a stuck pig, you know, so we want to make sure that we're using some sort of a non-adherent dressing on those. So that's perfect for those. So we like that
That
one.
makes me think of something. One time when I was doing yoga exercises back when I was in my 30s, a certain yoga pose that I was doing somehow, well, let's just say these are my toes, where the toe and the foot came together. One day when I was doing that yoga pose, the skin right there broke open. Is that the kind of
Kind of. Usually with the skin tear, there's more of like a mechanical injury.
A mechanical
so the
injury?
skin was brushed against something that was going the opposite direction.
Oh,
so
okay.
if you are falling and you know, your skin is obviously a constant, but if you were falling and maybe you brushed your arm this way, that skin might peel back a little bit. So we try to keep those moist. We might cover them with something like this. This is called a bordered foam dressing. It's made of silicone. It's nice and kind of, there's like a big cushion in it. We don't see a lot of patients that react to this adhesive. That's another thing we need to consider. There are a lot of patients that can't use tape. They can't use certain products because they're allergic to them.
I am
So-
to certain adhesives.
Me too.
You know,
Me too.
certain types of Band-Aids I
Yep.
cannot use.
Yeah, so these ones are typically safe. I've been in outpatient wound care for about 14 years now, and I may have only had one or two patients.
Oh, you've been a
that
patient yourself for wound
No,
care?
I've been working in outpatient wound care.
Oh,
for
you've been
15
working
years.
in
Yes, I did
outpatient
use
wound
one of these when I burned my arm.
Oh,
trying to
okay.
get a tray of dinner out of the oven and protecting my dog from sticking his face on the oven door.
Oh.
But I've only had a handful of patients that react to that one. Another dressing that we use, this is a little different. So this dressing is considered a hydrofiber, but it will absorb that drainage. So if your wound is draining, a lot of our patients with those venous ulcers will have wounds that just drain, and their socks are soaked and their shoes are soaked.
And you don't want the wounds to be that wet.
Correct. So we'll use something like this to put on the wound, and it'll just help absorb some of that drainage, but at the same time it'll keep that wound moist. So we use this too. And we can use this under our compression to help with those venous ulcers. I also brought, we were talking about diabetics and their feet.
Yes.
And how important it is for them to check their feet. So I also brought this guy here. This is a total contact cast.
A total contact.
Total contact cast. Yes. And so we use this. A lot of our diabetics will have sores on the bottom of their feet. And if they're not wearing the proper footwear, what's going to happen is they just keep stepping on it and stepping on it and stepping on it. So then it almost turns into a pressure component. So we have to get that pressure off of that part of the foot. What this does, this is the one that we use at Westfield, and this is the one that we use at St. Vincent as well. This particular, it's a cast system.
But it's mainly designed for diabetics.
Diabetics with a foot ulcer. Sometimes we'll use these for patients. Feet can be very funny. They come in all different shapes, all different colors. Maybe if you're not diabetic, maybe you have arthritis in your foot. Maybe you were in a car accident and now you have this deformity in your foot. This is really used for anything to relieve pressure on the bottom of the foot. So what we do is we'll put the dressing on, And then we'll do the different layers of the cast, and doctor will come in and roll this cast on. If you want to lift it, it's actually very light. It's a lot lighter than an orthopedic cast. It is a little more breathable as well.
Yeah, it's soft and fuzzy on the inside, but kind of waxy
outside.
Feeling on the outside.
So what this does is it actually locks the ankle in a 90-degree position. So now you can't flex your foot to walk.
And
so
put the pressure on that part of the
exactly.
foot.
So now you're almost forced to walk on your heel. So now we're doing good wound care, right, on the sore, and we're taking that pressure off so we can make sure that this heals. So this particular brand, their wound care supplies come in all sorts of different shapes and sizes. This particular brand, you actually have to pair with the boot. So if you notice, there's like it's almost like a netting, right, on this cast. In the boots, there are these little projections inside of this boot. And what those projections do is they actually lock into the weave of the cast to help take some of the weight from the foot up into the calf. So the bottom of this cast does get very, very slippery as well. So we use it as a cast system. So should you have that diabetic foot ulcer and we put you in a cast, we will tell you, you cannot wear this cast without the boot. So then we'll Velcro you in.
Okay.
And this is your new footwear, basically.
So there's good tread on the bottom of this?
There is good tread on the bottom of this. You do treat it like a regular cast. You cannot get this wet. So there are cast protectors that they sell at Walmart, at the pharmacy, on Amazon, and we usually recommend that. A lot of our patients will just use a garbage bag. You know, it really just depends. But this system goes together, and then your patient, because they can't really flex their foot, kind of walks on their heel. Now, if your sore is on your right foot and we put you in one of these, you will not be able to drive.
Oh, okay.
Yes.
Okay.
Yes. So it does become a little bit of a challenge.
Okay, so then you have to have everybody drive you every place you need to go. Then,
You
if it's on
do.
the
So
right
it is
foot.
a little bit of an inconvenience. If our patient, maybe they have a diabetic foot ulcer, but maybe they maybe they're awaiting a hip replacement or a knee replacement. Maybe they are elderly and they use a walker. We do go through a pretty extensive assessment before we decide to put somebody in a cast. The last thing we would want is to put somebody in a cast and then they fall and they end up with a broken hip or, you know, a broken arm or anything. So we do check their mobility and we worry about, you know, if we would put them in the cast, would they be able to navigate some of those surfaces?
Okay. Yeah, there's a lot to this wound treatment, isn't there?
It's way more than just sticking a Band-Aid on it and calling it a day, that's for sure.
Was that everything that you had brought to show then?
I do have one more thing.
Oh, okay.
So another treatment that we do, all of our treatments are ordered by the doctor, and then a lot of the dressings are applied by the nurses. So I don't have the other piece to this, but if you have a wound that is deep, right?
Oh, okay.
Some of the typical treatments that we do don't work, or they're not working as fast as we'd like them to. So this particular dressing is part of the big name for it, the generic name is negative pressure wound therapy.
Negative pressure wound therapy.
Yes.
Okay. Is that like a sponge material?
It is like a sponge, yep.
Okay.
Yep, just like a sponge. And
Okay.
so what we do, as long as your wound is infection-free, cancer-free, if doc, you know, says, hey, I think they need a wound vac, is the trade name for this particular.
Wound vac?
Wound vac, like a wound vacuum.
Okay.
Okay. So think of it as like when you vacuum your carpet at your house, right?
Okay.
You vacuum it to suck up all the crap, right, and get it off your floor. This basically does that. It sucks out all the drainage from your wound. So then we have that moisture managed. This foam, right, when we put it together, we put the foam in the wound, we put this drape on top, and then we put this little pad right on top like this. This is actually connected to a pump.
Okay, I was just wondering if
Yep.
that was what you were going to say, something to
Yes.
squeeze.
Yep, so
Yeah.
the pump actually is what provides the suction. So then this will kind of suck down on that wound. And what happens is that foam will help to pull those wound edges together. We want our wounds to heal from the inside up, not the other way around. And so with some of those deeper wounds, like an abdominal wound or a wound on somebody's backside that maybe the doctor had to go to the operating room and clean it out really good, a lot of times we use this treatment to help that healing go much faster. So this is actually, these two are probably, of all the things we do in the wound center, right, the compression wraps and just the basic treatments and everything, these two are probably my favorite to do.
Okay.
It's a lot of hands-on, and it's a little bit of arts and crafts, and
Oh, arts and crafts.
a little bit. We do get very creative sometimes with how we can get these dressings to stay on.
Oh, okay.
So.
Okay.
And that was all I brought.
Okay. Well, I'm glad you did bring them so that we would have something to look at to understand how you do things. Now, as far as wounds go, we're not talking about broken bones.
No,
No.
no.
Now,
there are instances where maybe our patient did have a broken bone. Maybe they fell and they broke their leg, and they had to have some surgery
because
to
of
repair.
maybe it was like a compound fracture.
Right. Sometimes we see patients that maybe they have hardware in their leg, their arm, whichever, and their surgical wound doesn't heal. Sometimes that hardware does get infected, and that could be that underlying factor for why that wound isn't healing. So that's part of the reason we do such an extensive workup.
Oh, yeah. Yeah, because you really have to know what you're dealing with.
Yes.
Yeah.
Yes.
Yeah. Well, you probably check people's vitals when they come in for appointments,
We absolutely
right?
do.
And that would include blood pressure and pulse.
Yep,
and
blood pressure, pulse,
temperature.
temperature, and we put the little probe on to check your oxygen saturation as well. We do that at every visit. Just like when you go to your primary care doctor, they should be doing that as well. And then we also do an after-visit summary for our patients, which is basically a packet. Those vital signs will be on there from what we got that day. And then there's instructions for what we did to your wound, right? So if we put that compression wrap on, there's going to be instructions about how to care for that compression wrap. What do you need to do? Basically, leave it alone, leave it dry. If it gets wet, if you notice any drainage coming through, then you call us. But we do give a pretty detailed packet of instructions before you leave, so then that way you know what to do. Sometimes those instructions will say maybe there's a family member that's helping to care for that wound and that's able to change the dressing. There's going to be a step-by-step instruction on how to do that and what to use and where these supplies are coming from. Maybe you have the nurse coming and that your instructions will just say, this is what the nurse is going to do. We'll send the orders for the nurse over. You can have a home nurse
So you
and
can,
come to the clinic.
You can get like a visiting nurse to take care of like homebound people.
You said it, Gail. Homebound is the key word. So if you don't drive, if you rely on somebody for transportation, we might be able to get a nurse to come to the house to help change this on the days that you don't come to the clinic. Now, if you are still working and you have one of these wounds that needs changed, you're going to have to make other arrangements, whether you come to the clinic twice a week to see us and we help you with that, or whether you bring a family member and we can teach them how to do it, a neighbor, sister, friend, retired nurse that lives down the street. We've done and heard and seen it all. But we do work very frequently with the home health agencies around here.
And then people who have the wounds that you treat, they, as a general rule, they're able to go to work and everything? Are they?
It depends.
It depends on the wound?
It depends on the wound. It depends on the extent of their injury. A lot of our patients that just have these compression wraps here, they can work. Usually sometimes we might ask if their work would be willing to provide an accommodation for them. If they have a job where they're standing all day long, we might ask that, they get an hour-long lunch instead of
a
half an hour, so that they
lunch.
can elevate their leg either on a chair or, sometimes I've even seen it where they flip a garbage can over and they use a garbage can just so that their leg is up and not in that dependent position. Some of our patients that are working, when we put them in a cast, we might ask, if there's an option for some sort of a leave of absence, maybe a short-term disability, something like that, depending on what they do. Some employers would be okay if their employees came in with this on their foot, and some would not. So it really, really just depends on what the injury is and what this person does for a living.
Okay, so you don't treat sprained ankles?
No.
There, okay. I'm just checking all these
No
things out.
sprained ankles. If you would come to us and say, I have this extra lump on my leg and it's covered with skin, we're not going to open that up. We don't treat rashes. We are not dermatologists. There's a big difference between actual wound care and dermatology. The biggest rash that we typically see is usually kind of in the trunk and in the peri area, in the diaper area. And that's typically what it is. It's basically an adult version of diaper rash.
We do. But you work on that?
We do see that on occasion. We usually will say use a barrier cream and call us if it doesn't get any better. But typically, if you're managing that incontinence, then that should go away.
You shouldn't be having the problem anyways.
Right.
Yeah, well, I know some people who have dementia. In the later stages, I've noticed, they don't think about going to the toilet.
Sure.
So
even some of our dementia patients, when we try some of these treatments, sometimes it is trial and error. Some of them will do very well.
So you do have dementia patients that come in with wounds.
Absolutely.
Okay.
But sometimes we'll put this on and they do very well and they leave it alone, and others within 10 minutes, or even as we're trying to put it on, they're trying to take it off. So like I said, we do have to get a little creative with, what's going on with our patient and how are they going to tolerate it.
I remember one time when I took an elderly woman that I knew to her podiatrist appointment. I remember just screaming and carrying on like they thought the podiatrist was hurting them or something.
Sometimes it is hard for them to comprehend what's going on.
Yeah.
Should we see that dementia patient, a lot of times we'll ask if there's a family member or someone that patient is comfortable with, someone that they're familiar with, to come with them.
Yes.
We do encourage somebody to come with our patients.
Well, a dementia patient wouldn't be able to come alone anyway.
Right. We do think, though, it's always better to have two sets of ears. As the patient, sometimes we might go through an extensive list of, we think it could be this and it could be this, and we want this test and this test and this test. And sometimes that's a lot for one person to catch everything and be able to hear that. So we do encourage a guest to come with our patients so that, kind of everybody's on the same page, but it's another set of ears to kind of hear what we're saying too.
Okay. And so usually you find out about these wounds from another doctor, another type of doctor then?
Usually. We do have a handful of patients that will call and ask for an appointment, and our front desk will tell them, contact your family doctor for a referral, and then we're happy to get you scheduled once we look at the record. But usually that's how we find them. Sometimes they get referred from the emergency room as well. If they, maybe they went to the emergency room for this issue because they didn't know where else to go, or it just happened and they didn't know what to do, we would take a referral from the emergency room as well.
I remember one time in the month of November when there was a few inches of snow on top of a thick layer of mud. I slipped and fell and hit my forehead on a log where there was a little branch that had broken off. And that's exactly where my forehead came down, was where that
Right
thing right
Oh,
there,
geez.
and it took out a piece of my forehead about that big around. I remember having to have my husband drive me to the emergency room. But I guess that probably wouldn't be anything that you'd be able to do because
We typically don't do those we would consider that a very acute traumatic injury. We typically don't see a lot of those. Usually they are from the emergency room first. We really don't use a lot of sutures or staples in what we do because a lot of the wounds that we see are deeper. So we do want that healing from the inside up.
yeah, they just bandaged me up, after sitting for hours in the waiting room because they were having a busy night, holding a washcloth to my forehead to apply pressure.
Yes.
But I thought I was going to get knocked out, when I felt my head hitting that.
Oh, I'm
lung.
sure. Or seeing all that blood. We do, surprisingly.
There was a lot of blood. It was all over in that snow.
Yes, your head is very vascular, so any type of injury to your head, it's going to be a bloody mess.
Yeah, something like that you'd have to do right away, not wait until you could get an appointment.
Correct, and that's another reason that we ask for a referral. There are some types of wounds that we cannot help. They might require more of a specialist, like a plastic surgeon. Usually anything on the face, anything on the scalp or the head, we typically will say, we're not the right place. We don't want to waste your time. We don't want to waste your copay. We think you need to see a surgeon. And the docs that we have at A.H.N. Westfield are not surgeons. So.
Right. Now, one thing I was wondering about, I know you guys are not registered dietitians at the wound clinic.
No, we are not
but,
that either.
If you suspect, maybe, do you refer people to dietitians? If you suspect that maybe their diet might be helpful.
We
if
do.
they make some changes in their diets.
We do. A lot of times, especially in wound healing, the two biggest areas of the diet that we find issues with are glycemic control. So if you're a diabetic and you're not watching those sugars and those carbs, and salt intake and protein. You need protein to heal a wound. So if we do have that elderly patient that maybe, they don't have a huge appetite, or, I only eat once a day, or whichever. Sometimes we will recommend a nutritional supplement like an Ensure or a Boost or a Glucerna that has extra protein in it. Those kind of help not only with a little bit of calories, but they help to get that nutritional balance that we like to see. We do refer our patients to dietitians. More of the issue is if you are not diabetic, a lot of times that's not covered by your insurance.
Really?
So you might have to pay out of pocket for that. As valuable as it could be, you may have to pay for
because
it.
I'm thinking people who've had heart bypass surgery or something maybe really should be put on a special diet. I mean, that's a complaint that I have. I mean, if somebody has a heart issue because they have been eating too much of some stuff, that's a complaint that I do have, that I do really think that doctors should not just do the surgery, but see about getting them some advice to prevent further problems.
So a lot of our doctors at Westfield also work down at St. Vincent. A lot of our patients, especially our cardiac patients, do go to St. Vincent for further cardiac care or cardiac surgery. So I can only speak for the St. Vincent program, and I know they are a heart recognized program, but I do know that they do have protocols that they do meet with a dietitian, or that the cardiologist or his extender, like a nurse practitioner or physician assistant, will go over a bit of a specific diet plan for those patients, whether it's a congestive heart failure, whether they just had bypass, anything like that. But I'm not sure if you would go to Buffalo. I'm not sure about how those programs work, if they do the same.
Yeah, because you work at St. Vincent's. You don't
Right.
work in Buffalo,
No.
so you don't know how they do things.
Nope.
Well, is there anything else that you should mention? We've got about a little under 3 minutes left.
If you have a wound that you've had for a while and you just aren't getting anywhere with it, we would love to see you and see if there's anything that we can do to help. So go ahead and call your family doctor. If you don't have a family doctor, I highly, highly suggest you get one. We do work in tandem with them quite often for different issues, but we would love to see you. We would love to see what we can do to help you get it healed. If you have any more questions about, what exactly do you do at the wound center, anything like that, feel free to give us a call. Any one of our nurses there are happy to talk you through it,
Okay.
and they're happy to take the time to see if you have this wound, maybe you would be a candidate for the wound center or maybe not, kind of a thing. So we certainly don't want you to wait. This is, wound care is similar to any other type of preventative medicine, right? You have a colonoscopy to see if you maybe have colon cancer and to prevent that colon cancer. At the same time, when you have a wound, we want to get it taken care of and we want to get to that root cause so that we can prevent it from happening again. But our team is fantastic. We'd love to hear from you. We would love to see you and see what we can do to help.
Okay, so how can they call you, or is there a website that they
If
can go
you
to?
search through A.H.N, you can find it. There's not really a lot of information on the website just because it's so much, right? There's so much in terms of what type of wound do you have, what else is going on, But you can certainly call the clinic and one of our nurses would be happy to talk to you. Now, they might have to call you back because we do
of
see
course.
patients.
Yes.
We do have patients that are scheduled. We are not a walk-in clinic.
No.
So they will call you back. Usually within 2 business days if it's nothing urgent.
Okay, well, I really appreciate your being willing to appear on Fresh Perspectives.
Thank you so much for having me. I had a great time.
Oh, you're welcome. And I hope the viewing audience, if they need help, that they take your advice. And
Me too.
because we don't want bad things to happen to people. So I will see those of you in the viewing audience on the next episode.